So let's go ahead and get started. We want to thank everyone for joining us this Friday for the next installment of the His Health webinar series. My name is Amor Amoyge. I'm the Associate Director in Health Equity and Healthcare Access here at NASDAD. I'm managing the His Health project. We are very, very fortunate to be joined here today by Drs. Friedman and Dr. Udoh, who are headlining respective programs around sexual health for young Black men who have sex with men. Today's webinar is entitled Community-Based Participatory Programming and Research for Black, Gay, and Bisexual Men. Both Drs. Udoh and Dr. Friedman will talk about leveraging community engagement and provide some specific concrete examples and action steps and best practices for incorporating participatory action as part of HIV programming and research that is focused on Black MSM patient populations. I want to first introduce Dr. Friedman. Dr. Friedman is a native of Chicago. He is a principal investigator for Project Silk, and his current work focuses on the design and implementation, evaluation, and scale-up of an HIV prevention demonstration project with young Black men who have sex with men, as well as trans individuals. Dr. Udoh is the Director of Monitoring and Evaluation for Pangaea. Am I saying that correctly? Pangaea, almost there. She's also the Research Director for Pangaea's Oakland NIH study. She has extensive experience in implementing international and domestic HIV/AIDS programming, monitoring, and evaluation activities in low-resource settings around the world, including the Caribbean, Asia, and the United States. So I'm really fortunate to have them on deck to share their experiences doing this very important work around elevating the standard of care for Black MSM. And with that, I'm going to turn it over to the panelists. Take it away.
Hello, everyone. Good afternoon. Thank you for being here with us today. I'm really pleased to be able to present this information and these lessons learned from both Project Crush and the Project Silk. Again, my name is Ifeoma, and our presentation with my co-presenter, Mackey, who's on the call, Mackey Friedman, is called Community-Based Participatory Programming and Research for Black, Gay, and Bisexual Men, Lessons Learned from Crush and Project Silk. So just very quickly, an overview of our presentation and what we plan on covering for the day. Next slide, please. I'll provide an overview of the Crush project. I'll also talk more specifically about what is community-based participatory research, what does that mean, what are the approaches around that, how is it defined, and then from that talk through the continuum around community-based participatory practice, which is moving the research into practice and into programming, and how that's defined. And then my co-presenter, Dr. Mackey Friedman, will talk through some examples specific to Project Silk, and then we'll give you all some outcomes and lesson learned and takeaways from both of these programs and how best to sort of incorporate community-based participatory practices into your own programs or your own research studies that directly can have great impact on the ability of Black, Gay, MSM to access services and access treatment. Next slide. So again, the project that I'm specifically going to talk you through a little bit today is called the Crush Project. Crush stands for Connecting Resources for Urban Sexual Health. The acronym itself is something, and the name itself is something that came directly out of our work with engaging young Black, gay men, and transgender persons in Alameda County and in Oakland, California. So I want to be able to give credit to that. That did not come from me. And the Crush Project really is about establishing a sexual health clinic for young MSM, primarily MSM of Color in Oakland, California. Next slide. So some of our key questions as to why a specific clinic for young MSM was needed, and what would that model look like? If we build it, what would it look like? So a little bit of background. Here in Alameda County, and specifically Oakland is the largest city in Alameda County, California. We're in the northern part of California in the Bay Area. MSM between the ages of 18 and 29 make up about 81% of all new cases between 2010 and 2012. So it's quite a large number of folks that are being impacted by the HIV/AIDS epidemic here, primarily young gay men. And the Affordable Care Act pushed younger people to become insured. We're seeing a lot of what's happening specifically around Obamacare and how that's being implemented here in California through Covered California to try to get younger people into routine health services and to become insured. However, and this is a point that I always try to make in any presentation where I talk about CRUSH, there is not a municipal or publicly supported STI clinic in Alameda County. In a county of 1.2 million people, we don't have an actual public health clinic. We have a few Planned Parenthoods. We definitely have our big hospital centers such as Kaiser and such as East Bay AIDS Clinic, which is where CRUSH is located. We actually don't have any clinics, standalone clinics that are located in the county. So this sort of push-pull tension between trying to get people into care and into services, but actually not having any places for them to go to became one of the critical questions that we were trying to answer with why CRUSH and how CRUSH could support that and bridge that gap. Next slide. So in 2013, the California HIV/AIDS Research Program, CHIRP, created a funding stream called the Epidemiological Interventions Initiative. And the goal of that was to really explore how to best integrate PrEP into existing HIV care centers. And so, again, a little bit of background. Remember that the FDA approved PrEP as a biomedical intervention for HIV prevention back in 2012. But many folks across the country and across the world are still trying to understand, well, how do we actually implement this? What are the implications for providing it to specific at-risk populations? How people are going to take it? Will they take it? What are the adherence messages that need to be attached to PrEP? And the state of California really took on those questions around wanting to understand how best to implement PrEP by leveraging funds through the state to look at how best to implement PrEP into existing HIV care clinics. And so CRUSH is, with the specific goal of CRUSH is actually that, to integrate routine to implement or integrate routine sexual health services for young men who have sex with men within the setting of an existing HIV primary care clinic. So it's really trying to establish a model for sexual health care for young gay men. And again, just speaking through about why that was important for us to root that in the context of sexual health is that we really felt that PrEP is not a standalone biomedical intervention, that it really needs to be seen as something that's rooted in the context of providing routine sexual health care services which don't exist in the county for a particular group of people. Next slide, please. So the specific aims of CRUSH were to, 1, test and link 400 young MSM of color into sexual health services, to enhance and evaluate engagement and retention strategies for young HIV-positive MSM of color, men who have sex with men of color, and I'll talk a little bit about that, and to engage and retain young HIV-negative MSM of color in sexual health prevention services, including PrEP. And specifically, just while this conversation focuses on using community-based participatory research methods, practices, I do want to say that one of the things that's very important to us about the CRUSH project, and particularly, again, about rooting this idea of integrating services in an existing HIV clinic, is that we believe that young gay men of color are involved and participate and are connected in the same social circles, whether or not they're HIV positive or HIV negative. So while there's great attention on the need to look at how best to implement services like PrEP and like PEP, we also were very clear that in terms of implementing sexual health care services, that we needed to be able to target sexual health care services across the HIV/AIDS continuum for both HIV positive and HIV negative men. Next slide. So again, how do we do this? What does a sexual health care clinic for young MSM look like? If we build it, will they come? And who do we need to include in the process of building it in order to make CRUSH happen? And so this really, for us, invokes the need for critical community input and buy-in and commitment. We could not imagine what it would mean to implement a program or a research study looking at sexual health care services for young gay men without actually asking the folks that we were trying to get into the services, well, what does it look like? What should this model look like? What do we need to So that takes, next slide, that takes us into really the rooting of our project, from thinking through what are the community-based participatory research approaches that we wanted to integrate into the study. So again, just for clarification, CRUSH is a demonstration study. It is a research study aimed at exploring the uptake factors and the barriers to sexual health services for both positives and negatives. So given that, there are a lot of pretty strict outcome measures, biomedical and behavioral, that we're looking at for the project. However, we were very clear that in order to actually answer those questions and think about what was the best mechanism for getting answers to those questions, that we needed to root the project in a community-based participatory research approach. And Kellogg has a nice definition of what that means: a collaborative process that equitably involves all partners in the research process and recognizes the unique strengths that each brings. CBPR brings with a research topic of importance to the community with the aim of combining knowledge and action for social change to improve community health and eliminate health disparities. And that's exactly what CRUSH is looking to do, to look at how to reduce these health disparities for young Black gay men of color that are directly impacted by the HIV/AIDS epidemic, and how do we actually bring them into the conversation so that they can tell us how best to do that. Next slide, please. So some of the core principles of community-based participatory research are that we recognize the community as a unit of identity, that the community is huge and it's large, and that there are lots of different ways to define community, but the community should tell us what that looks like. We should actually engage with who we're trying to see for our work, to have them tell us, well, who needs to be at the table. It also builds on partner strengths and assets. It focuses on locally relevant problems and social determinants of health. A big one for us, which I'll talk more through some core examples of how we did this, was the co-learning and power sharing process. As many of us know, when we are engaged in research projects, I myself being a researcher, Mackey himself being a researcher, that there's always this sort of push-pull tension between community and research that we need to acknowledge and be very clear about in terms of the power dynamics, in terms of things that are important at an academic level versus things that are important at a community level. And do those things need to be in polar opposites of each other? We believe not. And so embedding your work within the context of co-learning so that every party who's participating in the process learns and grows and is in ownership of the study is super important. And we have some examples of how we went about that. Systems development and local capacity building is another big core principle of CBPR. It balances research and action. So again, this idea that we were learning about how best to implement sexual health services, but we were actually implementing sexual health services as we do it. So it's sort of combined, and it's thought about as action in the research. And commits for the long haul to enable sustainability. And that is definitely what the goal is of CRUSH from the onset. And as a matter of fact, while the research study itself is ending next year, the clinic itself will still continue, and the clinic services around CRUSH will still go on. So we're really happy to have that be one of the core outcomes from CRUSH. Next slide. When Mackey and I were talking back and forth about putting our slides together and realizing that there were so many synergies around thinking about CBPR from a research perspective, from a programming perspective, one of the things that was very clear to us was this idea that we come into our work from a perspective of having cultural humility. And specifically because we're talking about what it means to empower Black gay men, what it means to listen and hear Black gay men and understand the core beauty that they bring to our work, and what it means to understand that they know better in terms of what needs to happen in terms of our projects. It makes us realize that there's a place of humility that we have to come in, sort of this where and where you enter. Being trained as an anthropologist, that's something that's very important to me in terms of my work, how you enter into the work, how you enter into conversations, how you enter into a dialogue to understand if the things you're doing are the appropriate and right things. Strikes up sort of this need to address our work within the context of cultural humility. So I wanted to speak about that a little bit and show you a definition that comes directly out of a doctor here in the Bay Area, Melanie Turbalon, who's done a lot of work with perinatally infected youth in the Bay Area. And the definition from her is that a lifelong commitment to self-evaluation and self-critique to redress power imbalances and develop and maintain respectful and dynamic partnerships within communities. And so I think both of these examples between CRUSH and Project Silk will hopefully share with you how we've approached coming into our work with a sense of cultural humility. Next slide. Community-engaged research, what's the value? What does it mean to actually have the community fully engaged in your processes and in your procedures? Well, one thing for us that's been incredibly clear that the answers to understanding what are the best ways and practices towards implementing sexual health care services means that we focused our questions more specifically on the issues that matter to the community. And some of the ways that we've done that is that we've had direct community-based forums, and we have a CAB, which I'll talk more specifically about, where those procedures and those processes really inform, are the questions that we're asking the right questions? Do we need to be heading in different directions? Next slide. So some of the ways that we thought specifically, concretely about implementing CBPR practices within our study was, one, by establishing a robust community advisory board. And for us, community advisory boards are not taken lightly. I think throughout projects and histories and different experiences that I'm sure a lot of us have had on this call, you always hear about a community advisory board that is connected to a project or connected to a research study. And for us, we wanted to make this CAB an active part of what we do, and a very concrete active part of what we do. We gave them specific responsibilities and had them tell us what responsibilities that they wanted to take on as a part of the work. So things like developing our outreach materials, which I'll show some examples of, developing our amazing website, which again became a huge conversation with the CAB about, well, what are the images that we want to express about Black gay men, and what are what's the language that we want to use, and how does that look in terms of how we represent them in the world. So lots of conversations around those designs and really engaging their trust around that process. But also within the clinic space, engaging young African-American gay men to come into a healthcare system. It's not an easy thing to do. There's a lot of clinic there's a lot of historic mistrust of the healthcare system that we need to acknowledge and be aware of as we were implementing these services, and we needed to be able to talk with our providers about that, talk with the staff about that, and set up the clinic as a safe space specifically for youth. And we'll talk more about how we did that as well. But really, we see our CAB as ambassadors to the CRUSH project. They speak on behalf of the project. They are who we call on when media wants to talk with us about how are our services going, what are the studies, what's participating in the study like. We've had several media events where we've had visitors from around the world coming to see how we've implemented the CRUSH project, and we've always encouraged and had a CAB representative with all of those conversations. Our CAB has represented us on things like youth radio and NPR. They come to all scientific fora that we've been invited to. We take them with us to our conferences. Our CAB are our ambassadors. They speak on behalf of the project. They can tell people better about what we're doing than we can. And then, of course, our patients and our participants in the study are absolutely important and core to the engagement strategies around bringing young MSM of color into clinical settings. Next slide. So one of the ways that specifically that we activated our CAB is that our CAB, our community advisory Advisory Board and our partners are entwined. CRUSH is a huge collaborative study, and again, rooting that idea of the project within CBPR. There are several partners that participate in the CRUSH study that I'll mention in a few minutes. But the CAB and the partners are intertwined. So our Community Advisory Board is a combination of young men who are either participants of the study, have been on PrEP, have accessed sexual health care services at one point, or just want to know more about what's going on in their community. And then our community partners, of which we have 3, which I'll mention in a few minutes, also have representatives that sit on our CAB. And so there's a dialogue that's happening between the actual implementation on the ground and the community that's actually accessing services as part of CRUSH. We don't see them as separate. There's an ongoing conversation that's happening throughout the course of the project. And again, as I mentioned, the CAB has developed our outreach materials, and they've developed our website, including the hashtags and the naming of our website, which our website is called www.crush510.org, and 510 is the area code for the main cities in Alameda County, Oakland, Berkeley. So those sort of concrete outcomes of how they engaged in the process of doing the research and doing the recruitment are some of the key core responsibilities that we've had in place with our CAB. Next slide. Again, our CRUSH project, our CRUSH study is a huge collaborative effort among several partners. The East Bay AIDS Center is where the main clinic actually lies, but we also work with UCSF CAPS. We work with Gladstone Institutes, and in particular, Dr. Robert Grant, who was the original protocol chair for the IPREC studies that determined that PrEP was a viable way for HIV prevention. The Clínica de la Raza, HEPAC, Casa Segura, which is the local needle exchange program here in Alameda County. My organization, Pangaea Asian Health Services, which is a primary care site here based in Oakland, and Rise Youth Center, which for us was really important to include a non-HIV/AIDS specific partner as a part of this work. So while we are working to improve the sexual health access for young gay men of color, there are other social spheres and social qualities that are important to incorporate into that work, and RISE really helped us bring that framework to the table. Next slide. So thinking about the continuum from research to programming, as I mentioned, CRUSH is a research study where we're looking at specific outcomes around uptake of sexual health services, including PrEP and PEP. But we're also very clear that the idea around research is that eventually what you learn can be put into practice, can be integrated into a specific programming context. And again, as I mentioned before, while the CRUSH study itself will be ending next year, the CRUSH clinic, the services that exist in that clinic, routine sexual health care services, access to PrEP, access to PEP, will all be continuing beyond the 4 years of the study work. And that, I think, has been incredibly important for us to keep focused on as we implement the research study. While we'll have, we hope, some tremendous findings to talk about what are the barriers to access to PrEP and to PEP for young African American men who have sex with men, we also were very clear that the legacy of the study is that it continues on and moves into a programming context, that this existing standing HIV clinic that before we got there was only seeing HIV positive persons has now figured out a way to integrate HIV negative participants and patients into their work. And so the clinic has expanded its doors to see negatives as well as positives. And we think that's an incredibly important outcome from the research. And so as Mackey and I were speaking about the continuum from research to programming, and specifically sort of thinking through, well, what does it mean to go from CBPR into community-based participatory programming? My colleague had this to say, and I wanted to make sure that I highlighted it. A process through defined structures of good participatory practice, a commitment to stakeholder engagement, peer staffing, dedication to relevant programming beyond the needs of funders, continuous assessments of participant satisfaction with programming, and a willingness to act on information gathered from the community served. CBPP, Community-Based Participatory Programming, can be used to optimize recruitment, engagement, access, uptake, and outcomes by providing programming salient to the community that's being served. So I really appreciate that that we have that framework for discussing the continuum between research and programming. Next slide. And again, just in terms of highlighting that a little bit further, in traditional programming approaches and traditional research approaches, the community rarely has influence on the design or on the questions, right? So we've all seen these examples before where a research study gets funded, a bunch of researchers come in, and they have a big old question, and they go in and they start to implement that question, and things get stuck because there wasn't the time that was taken to understand the context, the influences, how to think about the design and/or research questions at the beginning of the project. But if those processes of engagement are put in place, if you have active levels of community engagement from developing questions to participation and dissemination of results, and that could come in a variety of ways, such as community forum, could come in a variety of ways, such as having the organizations who are local in your area come to you to hear about what research findings there are and have you help them help you interpret the data, is what you found out correct. So to solicit the opinions of the community through the entire process of implementation with your CABs, with your peer-based staff, there can be an opening that happens in terms of thinking about what community-based participatory research is. It leverages results and it leverages partnerships to promote social change. Partners are active in the implementation and the design, and outcomes can be more present that go from participant to partner and back and forth that hopefully have impact at a larger social sphere, some of which we'll talk about is some key examples from CRUSH and from Project Silk as we move forward through the presentation. Next slide.
Thank you, Ife. So I'm Mackey Friedman. I'm going to talk about Project Silk and kind of how it started and how it fits into this larger discussion of community-based participation in programming and research. And just to get us started into Project Silk, our State Department of Health asked us in 2010 to conduct focus groups with youth around Pennsylvania on some barriers to HIV STI testing. And this was part of the University of Pittsburgh, where I work. It was part of our larger role in trying to inform the community planning group for HIV prevention on youth issues, because we recognize that structurally youth were sort of disenfranchised from those community planning efforts. You have to be away for 2 or 3 days during the week. You have to be in Harrisburg, Pennsylvania. You're not necessarily getting reimbursed in a timely manner. It's very difficult for youth to attend and show up and be a part of those meetings. And we work to get youth included at a formal and voting level for years to get youth voices at the table so that you wouldn't have to kind of translate their experiences. And we also work to assess youth's experience accessing HIV and STI services so that they could also then report on findings from their own communities. And we really just tried to facilitate that process. And so we got some incredible information that helped inform policy in 2010 and kind of set a new direction for the state of Pennsylvania. And the state DOH was very supportive of our efforts to get some youth voice involved in this process. But there were some statements that we thought we could take even further than just the community planning group. And when we asked folks in Pittsburgh, especially in our young adult roundtable in Pittsburgh, Pennsylvania, about some of the barriers to HIV STI testing, the group there was constituted primarily of young Black, gay, and bisexual men and trans women, and they were mostly House and Ball community affiliated. between 13 and 24. And what they told us, above and beyond kind of standard or typical responses related to barriers like inaccessibility of hours opened and perceived discrimination and a lack of appreciation for the crumbling infrastructure of some of our public health buildings because of lack of funding, they said, above and beyond that, there's nowhere for us to go. How can we get something that's just for us? How can we get something that's a clinic and offers clinical services but provides more than that, provides a social space, because ultimately in this city there's nowhere for us to go and be ourselves and be authentic. And, you know, that wasn't something that we could do on a structural level with just the community planning group's involvement and support, which was there. It was something that we really needed to look elsewhere to try to meet. And so we found a granting mechanism that we thought might allow us to explore that a little bit further and try to set up this structure that provided safe space for young Black, gay and bisexual men and trans women here in Pittsburgh. And so we lucked out into a CDC demonstration project grant through Category C. Next slide, please. And that grant was focusing on piloting structural and behavioral interventions for young gay and bisexual Black men and trans women, or that's what we proposed. The structural and behavioral intervention piece was part of the CDC's granting structure. Also, innovative HIV counseling, testing, referral services activities that enhance linkage to care and retention to care. So we proposed all of those things in alignment with the granting structure, but we realized, you know, there's stuff missing from that, and that is, you know, what are the community goals here? And yes, even in some cases, those community goals cohere with what we wanted to propose. Community recognized that HIV was a major problem and wanted to be a part of the solution. But there were other things that weren't in the kind of standard grants package that they wanted to do, and so that's what we were able to kind of put in the grant, and that involved this creation of a safe space that allowed also things that the community really wanted, like a place to be, a place to avail themselves of services if they were there, but also a place to dance, a place to socialize, a place to watch movies, a place to go after school, a place to do your homework, a place to build resumes, and a place to build social capital and social networks. So all of those things were outcomes that were community generated that we wanted to be we wanted to just help facilitate and help happen through that process. And I should also mention that at the University of Pittsburgh, we are really proud to be part of a very historic project called the Pitt-Men Study, which is part of the multi-center AIDS cohort study. It's been around since 1984. It's I think, the longest standing HIV-related cohort studies of gay men in the United States. And since its inception, the Pitt-Men Study has prioritized community involvement and set up a community advisory board in 1984 to get community folks at the table talking about processes, talking about outcomes, talking about planning and design and recruitment. So that's been going on since day one, and Dr. Tony Silvestri, who's a mentor and was really oversees the HIV Prevention and Care Project here at the University of Pittsburgh, his teachings around community advisory board work were instrumental to the processes that we put in place through the development of project itself. So to go a little bit further, we also tried to insert some asset-based youth development practices, and that's in the published literature. It's really around giving youth an opportunity to thrive and develop develop skills that can be used on resumes, like group facilitation. Being an ambassador, a lot of the things that Ife mentioned are really important skills-building pieces that youth can then use to leverage to get jobs in the future. So that youth development component we thought was really important. We're extracting so much from our youth, their time, their energy, to push this project forward. What are we giving them in return? And it's really important to give back and give them skills that they can then use to leverage. So that youth development piece we thought was really important. So we started this project by having really extensive formative research and community discussions over a 6-month period, having stakeholder engagement really direct us as we move forward. And then from those community discussions, which we had a couple times a month, the kind of most frequent, most incisive, and sometimes the most valuable members we wound up choosing for our community advisory board, and then also looking beyond that core structure to see if there were folks from some communities we weren't hitting to also be members. And then from those initial meetings, they really established for us the, I guess, ancillary programmatic structure of what we do. They wanted it to be open 4 nights a week. They wanted it to be in an accessible location. So we hadn't rented a space yet, and we wanted to make sure we vetted our location with the youth who were involved before we started. And they wanted us to keep meeting that structural response to the need of there being nowhere in the city that they could feel comfortable with going and being who they were. They also suggested that there were both peer and non-peer alternatives to the HIV and STI testing that we were going to offer on site, because a lot of folks said, oh, I'd feel really comfortable getting HIV tested by a peer, and a lot of folks said, yes, but I also want there to be an option that we can talk to somebody that doesn't know us in case we're worried about privacy and stigma. So we wanted to offer both of those things, and really what it wound up being was this kind of constellation of client choice. And so all of that input that we got, I felt like, funneled into a protocol that we developed that tried to maximize patient-centeredness and client choice as much as possible, even to the extent that when folks come into our space now, they get a drop-down menu electronically of people that they can get services from. So if they want an HIV test, they can choose who they want to give them that HIV test. And we're to just maximize that choice in order to maximize uptake. So it's almost a customer service approach at that point. And what I want to mention is that the safety protocols that we developed when opening the space were really community developed and generated. And so it wasn't something that we had to say, no, these are our rules and you have to stick to them. These were community generated rules that the Community Advisory Board developed and refined and worked through. And in a lot of cases we had to really make them less strict than sometimes Community Advisory Board wanted, just to make sure that they were going to be in line with what was feasible. But they really wanted to maximize the safety of that space. And for us, as staff members, it's so much easier to enforce rules that are community generated than arbitrary rules that you just develop because you think they're right. So it really kind of helped establish both buy-in, but also responsiveness to the rules in place. So here are just some pictures of, as Ife mentioned, in Crush, youth were involved in so much of the kind of backdrop to program development, and here as well at Silk, up to the point where they were, besides helping us pick the location, they painted the space with us, they chose the name. We had an opening ball and party. This is Kiki Deluxe dancing for us when we first launched. And again, this wasn't necessarily, these weren't activities that our funder necessarily promoted or suggested that we do. They were things that we knew would help us establish community buy-in and really help folks feel invested in this entire project, because we wanted this project not to be about, oh, here's this work that we're doing. This is a project the community developed, and we are just lucky to be a part of it. So I'm going to move past that and just talk real briefly about the 7 or 8 core components that make up Project Silk. And so that's a recreation-based safe space to be open at times convenient for target population members. And that's also a response to those data that we got before we started this project, where folks said, well, these 9 to 5 hours of health departments don't really work for the hours that I can get an HIV or an STI test. In this case, we started by opening from 3 p.m. to 11 p.m. 4 nights a week, and we continue to be open on occasional weekend nights, especially for special events or for specific house ball parties. Right now we're open from 1 p.m. to 8 p.m., although those hours shift seasonally at times. But we are still open, you know, well beyond the 5 p.m. hours that typical agencies kind of have to abide by. And when you're a Department of Health worker, you have really set hours that you can't have a lot of flexibility to adjust, and that's one of the things as kind of a community-based agency, or as this academic community partnership that Project Silk has evolved into. We get to be a little bit more flexible with what we offer. We talked about the asset-based youth development structures for program planning, staffing, recruitment, engagement. We also think it's incredibly important that we have demonstrated cultural competency in all staffing and volunteer roles. It only takes one, and either at your front desk or as a volunteer, to really, it's kind of one apple ruins the whole, one rotten apple can ruin the whole batch. So if you get a really bad impression from a staff member when you go into the space for the first time, you might well never come back, and we wanted to make sure that does not happen here. We needed strong agency buy-in and support, because this work is not necessarily easy. In a lot of cases, you're working with extremely marginalized youth who have experienced a lot of violence victimization and might act out as a result of it. And you have to have a very resilient staff and a very resilient administrative component to the work that you do so that you can keep doing that work. That involves clinical supervision, it involves allocating resources from helping staff take care of themselves after dealing with multiply marginalized populations. We think that's just so important. Otherwise, turnover is going to be too high and there won't be continuity. Other things that we think are essential to this model are co-located mental health and supportive services. So a lot of that came from some of the deficiencies that we noted in programs dealing with multiply marginalized individuals, where folks who were HIV positive often had better access to services that were necessary than folks who were HIV negative, giving this kind of perverse incentive to seroconvert. And we wanted to make sure was to offer supportive services to everybody, regardless of serostatus, in order to not stigmatize folks who were positive, but also give the same access to folks who were HIV negative. We wanted to integrate HIV and STI testing and allow people to do self-testing with self-administered urine-based tests, to offer peer and non-peer navigation to PrEP, social services, HIV-related care, and to have a kind of philosophy undergirding all of it. So that's kind of Project Silk in a nutshell, and that's how we operate.
So again, some of the core principles you've heard from Mackey and myself around what the CRUSH project is and what Project Silk does are in terms of really rooting our work around the perspectives of the communities that we're working with and getting their buy-in and feedback and their active participation in the actual implementation and design of this work. Really, implementing CBPR practices and CBPP approaches in programming and research, it takes time, and that is something that I think we both understand as both researchers and as both people who are committed to community perspectives in our work. And a lot of times that also means that there's this need to address the resistance to engagement. Resistance that might be felt from funding perspectives, from your local and county health departments, from state public health departments, even sometimes at the community perspective, in that there can be a lot of resistance to actually encouraging this type of in-depth engagement. And our sort of response to that is that, you hear this resistance, at least maybe more from the sort of structural levels of funders and health department officials, and that the community may really not know what the real problems are, or they may not really know how to articulate what those problems are. And our counterpoint to that is that it actually knows exactly what those issues are. They know more than us, the researchers, and they also have lots of ideas about how to go about tackling those problems. And very clearly, we have some outcomes that we'd like to share with when you take the opportunity and the time to engage community at this very in-depth level and have them be your partners through implementation, through design, through dissemination to how you talk about results, that it really does actually move you further in the direction of having concrete outcomes, far more than some of the anticipated outcomes that you might have planned on for your projects. Next slide, please. Next slide. So we wanted to bust the myths around community-based participatory research and programming. And one of the myths that we hear a lot when we do this work is that it's really hard to capture outcomes. How do you generate outcomes from engaging community? And that outcomes can sometimes be more qualitative than quantitative, but that outcomes nonetheless are really difficult to capture when you take this amount of time to actually work with the people that you're trying to engage. But we actually have outcomes to share with you, and some concrete ones as well. Next slide. So specifically from CRUSH, we enrolled our first participant into the study in February of 2014, and our last participant enrolled in March of 2016, so almost to the day, 2 years of enrollment into CRUSH. And we enrolled a total of 381 participants into the study. Our main source of participant recruitment was the actual participants themselves. The folks that came into the clinic began to start telling other people that this clinic exists, that there was a place for them to come and to receive services, that it was a good place and a safe place. There was a recruitment, a retention coordinator there who's not with us today, by the name of Fonzie, who understands me, and Fonzie texts me back when I forget my appointment, that the MA, Maurice, is the same age as them and looks like me, and that it's a comfortable place to be. So our main source of recruitment into the CRUSH study itself was that it was the participants. The participants came, and then they went out and told their friends and people in their social networks, have you guys heard about CRUSH? Another big place that was a source of recruitment for us was that through engaging Black, gay, and bisexual men, we actually engaged a lot of people within their social networks, within their sort of social fears, and it particularly was very interesting for us to see a lot of young gay and bisexual men actually have a lot of women who were their friends who also became a great source of recruitment for us. So not just encouraging and working directly with Black, gay, and bisexual men, but also getting into their social networks as a source of helping us understand, well, where could we actively engage this population? And, for us, the idea is, we heard it from not only from our partners, but also from other participants, other researchers. If you build what's needed, will come. So this idea that if you build a clinic and you build it from the perspective of the community, they'll come. They knew that because CRUSH was there and they'd heard it from their friends, that they could come into this place and not be stigmatized and be well taken care of. Next slide. So again, just a graphic representation of our intake sources. As you can see here, from our total number of participants, the 381 that participated in the study, are participating in the study, many of those folks, whether or not they were HIV positive or negative, coming in for PrEP or coming in for sexual health services only, came in specifically because they heard about CRUSH through either study staff or the clinic staff. They also obviously heard about CRUSH through other community partners and community providers, which again was incredibly important for us to keep that perspective in terms of having a plethora of providers who I talked about earlier in the slide deck to participate with us. And then again, hearing about CRUSH from either other study participants and or community organizations. Next slide.
So I'm going to talk quickly about some of the other myths around community-based participatory research and practice that Ife and I both felt like we debunked with our programs a little bit. And one of those myths is it's too expensive, too much allocation of resources for what you get. The juice is not worth the squeeze. You know, you're spending all this time on community work and community resources and community this and community that, and you're forgetting about any outcomes. And that was something that we've heard frequently from funders, from other researchers, from people who aren't invested in this process. And so one of our outcomes at the end of the demonstration project period actually showed the opposite. It showed that comparing costs per new HIV diagnosis or expenditures per new diagnosis, which is I think probably one of the CDC's preferred cost-effectiveness analyses around HIV, we showed that Project Silk, in comparison with other HIV testing in the county, spent about $42,000 less on average to identify new HIV-positive clients. And then talking about another, I think, common myth with CBPR, which is you're so interested in the process, you don't care as much about the outcomes, and really there aren't any outcomes. Hasn't been the case for Project Silk anyway. We have had one of the highest HIV seropositivity rates in the jurisdiction, around 5%. There's been this kind of theme through the literature on HIV-related work with Black, gay, bisexual, and trans youth that they're hard to reach, and we have not found that. In fact, we found that our community connections and our community investments have made this population really quite easy for us to reach. In fact, we were crushed with, to take Ife's project's name, we were really crushed by participants who came to us right after we opened. We had, I think within the first couple of months of opening, over 100 people who came through our doors. We were not expecting in a small city like Pittsburgh that kind of crush right then and there. So we actually had to scale back our recruitment efforts just to meet the demand of the people who were already coming through word of mouth. And it was people that fit our target population. It was young people between the ages of 13 and 22. Our first year, I think our mean age was something like 18. It's risen a little bit to about 20. But we've always been able to reach that kind of adolescent young adult population really fairly easily. And in fact, we've reached, we have a mean of over 200 target population members a year coming to our space. So utilizing our safe space, which is more than 30% of the total estimated number of the target population of young men who have sex with men who are Black, African American, and trans women between 13 and 29 in the county. So it easily surpasses the threshold for community level impact. And then we had some unplanned findings too, where we had a high number of individuals who were previously positive getting re-engaged to medical care after receiving so-called ancillary services or supportive services at Project Silk. And we weren't anticipating, and it actually hadn't been staffing for that particular eventuality. But people felt comfortable in the space. They felt comfortable talking to the social workers that we had on site. They felt comfortable getting transportation, food, and other services, and so comfortable that they would, after 3 or 4 initial service provision requests had been met, would disclose being HIV positive and would talk, would be interested in talking about medical care and re-engagement and adherence counseling and all of those things that kind of come with someone who maybe has been out of the medical system for a while. And so that led us to really start thinking about and evaluating the importance of social spheres in communities that don't necessarily have a lot of spheres that are dedicated to their sense of belonging, their sense of being. And we feel that we've kind of helped show that creating a welcoming space for people engenders social participation beyond just service seeking, which can in and of itself lead to additional service seeking behavior, right? If somebody's coming in 4, 5, 6, 7, 10 times, not getting a service, but then they know the services are there, they're being offered. When they need a service, they can get one. They'll start availing themselves of their service if and when we need them, if and when they need them. And so that's been a really important part of our philosophy, is to set up this social sphere, let people use it the way they want to use it within the rules of that sphere. And the rules of that sphere do not necessitate utilizing social services or HIV-related services or anything like that. You can just be there if you want to. And then if you need a service, if and when you need one, you can get one. And that's all up to you. So we also feel like social spheres increase community investment in these projects, and that these spaces are a self-perpetuating mechanism for recruitment, for access, for uptake, and for all of the outcomes that you want and that your funders want. Even if your funders are sort of sketchy about the process that you've entailed upon, if you're meeting those outcomes, that's what's important. The other thing that we thought was really necessary in this project is that we could offer space and services that were independent of HIV serostatus. For one thing, being HIV positive is so stigmatized. Even now, at least in our small community here in Pittsburgh, we wanted to make sure that all of our services were totally independent of serostatus, so somebody wouldn't be marked as being HIV positive for just walking in the door or for talking to this counselor or for this counselor. Yeah. Everything was offered across our staff and across our space. And so one of the things that we established in viewing Silk as this alternative social sphere is it was an intake system to allow for clients to request services via their mobile devices or via devices that were on-site, like laptops and computers. To try to destigmatize service provision, they would enter who they were, they would log in, and they would be asked if they want a service, and they would be given a drop-down menu of who could offer that service and who they wanted it from. They would choose it. It would send an email to the people who were staffing, and then we could discreetly provide that service to the individual. So it really optimized client choice and let them avail themselves of the services that they wanted. And above all, we've let the Youth Advisory Board vet, establish, and maintain structure, peer-led educational programming, above and beyond the things that we put into our grant that are HIV-related. So wellness promotion, life skills workshops, role modeling, recreation and socialization programs. And we really feel like this peer-based navigation that we offer creates low threshold barriers to access, and that's what we want. We're trying to keep that bar as low as possible so access is as easy as possible for everyone who wants a service.
Thank you, Mackey. I really appreciate the feedback and the outcomes specifically around creating a space that is engaging with negative and positive and to not stigmatize based on status, because I think that was one of the things that was very important to us as well in terms of thinking about the CRUSH study, is that while we were implementing sexual health services with the hope that we can reduce the disparities around HIV infection for young gay men of color, the idea that gay men of color, regardless of serostatus, are all part of the same social sphere, and that the clinic itself had to be a place where positives and negatives, without fear of stigma amongst each other or from other people on the staff, including providers that had been used to only seeing HIV negatives or only used to seeing HIV positives for nearly 30 years since the clinic has been established, could actively participate in a process with both negatives and positives, and specifically Black gay men, young gay men of color, come through the door and come and access services free of discrimination and stigma. And so in terms of other outcomes or perspectives around using CDPR in action at CRUSH, one of the things that established early on was this idea that our community advisory board and our community partners could actively participate jointly and engage one another in terms of recruitment activities. And we established the Youth Corps, Outreach Corps, which were members of staff members at our local community-based partnerships, as well as with our CAB. And they would go out and implement activities and joint sessions together in order to talk about CRUSH, to talk about sexual health care in the community, which was huge. The idea that we were establishing a sexual health care clinic in an area that had not ever had one before meant that we had to engage actively at the community to ask them, what does sexual health care mean, and what should that look like for implementing these sorts of services and asking these kinds of questions in Alameda County. And that led us to also doing a thing that we call the CRUSH Roadshow, where we actually took members of our CAB and took members of our CBO partners into different community-based organizations across the county and put them into neighboring counties. You know, we move around a lot, and talk to them about CRUSH, talk to them about what we were doing, and show them the services existed, the services there, and how could we put them engaged in their environments as well. We also had opportunities to develop 2 short mini educational videos, which if you get the chance again to check out the CRUSH website, www.crush510.org, you'll see them on there, in which the CAB wrote the script for those videos and in some cases acted out the voices for those videos as well. So again, actively having our CAB help us think through what are the sorts of materials and the messages that we wanted to develop in terms of promoting sexual health and practice. Next slide. One thing that we're really, really proud of, and we feel like is an extraordinary outcome of the CRUSH project, is the development of the CRUSH website. And again, this was a long and drawn-out conversation, which, again, that idea that while engagement is important, it does take time and it needs to be thought of in a really concrete way. But we had several conversations with our CAB members and with our partners about, if we develop a website, what does it look like? What is the language that needs to be on there? How do we depict Black gay men of color, or men of color, gay men of color specifically? What are the images that we use to talk about this population and who they are and what do they want to see? And one of the things our CAB was very clear about is that they did not want to see the stereotypical images that you see a lot of times with promotional materials that come out of programs that are, you know, sort of show African American men or men of color engaged in social crafts and looks, and you see them covered in muscle-bound bodies. We're very fascinated with those sorts of images and stereotypical ways to present Black identity on our site. And so it's a lot of work to capture what was going to be appropriate and we visited a lot of different sites and we built something, and we believe we gave something where we presented their sexual happiness and their meaning that quite well from our website. So we have the opportunity to definitely take a look at that. Next slide.
Hey, I just wanted to provide some context of what do we mean by like extra or above and beyond programming in Project Silk that maybe wasn't anticipated by our funders or necessarily always something that they would support unless the outcomes were there. But the outcomes were there, and so really ultimately they did support these kind of above and beyond programs. And those above and beyond programs were, in my view, integral to the kind of outcomes we generated. And there were things like Beauty Day, where we bought wigs and makeup and clothes and allowed people to really learn about, well, especially for some folks who'd never done drag before, to learn about doing drag, or for some folks to learn about face, all kinds of ball categories to kind of learn how to really refine your look. Vogue 101 nights for folks involved in house and ball community to really learn, who are just getting into it, to learn how to do Vogue, or if you knew how to do it, to refine your skills. Games night, things like bingo. We also hosted mini balls. We've done things like healthy eating, yoga, stretching, meditation seminars on site. Interviewing for jobs, you know, things you should expect from people who are questioning you and your work experience, how to respond to those questions, what to say, what to wear. We have weekly sexual health discussion groups that allow for really open conversation about questions that people have about sexual health. We've hosted trans mixers to allow trans women an opportunity to be in the space just for themselves, and to have discussion groups and to have social events just for them, so they can feel safe and they don't feel like the butch queens are taking over, because that's generally what happens eventually. And we've had a space for house leadership meetings as well, so people who are leaders in the house and ball community can convene, and whether it's just your house that you want to talk with, or whether it's a constellation of leaders from houses around the city, it's a space to have meetings and plan for events and plan for better cooperation between houses, which are often riven by competition. So we've tried to offer a space that can kind of clear the air and clear some of those hostilities, and try to understand those hostilities, but really just be a community space for what folks in the community need. So here's some pictures of that, some folks playing games, some folks stretching, a mini ball, and an advertisement for game night. And I've talked a lot about these social sphere considerations. Oops, not going too far ahead. But I wanted to just reiterate that for us, the utilization of the safe space is not a bait and switch, it's not clickbait. You don't need to uptake a service. And that we trust that people will use the services if they're there. And I think that's really important in a lot of agencies that I've worked at in my community work. Often you need, the only way you can get in the door is to get a service from that agency. And so that, we want it to be more inclusive and allow folks to just come in. If they want a service, whenever they want it, they can have it. And to really encourage and foment this larger community site and space outside of just service utilization. The other thing that I wanted to say was that it's really important to be open, at least for us, to be open to alternative outcomes. So in addition to the outcomes that you expect, when we do client satisfaction surveys, or in this case we did sort of we're doing a larger kind of individual interview assessment of why people use the space and what it means to them, be open that the community might see different things and might see different outcomes than the funder sees. And it's really important to gauge that. First of all, there might be tension between those two different outcomes, and there might be a gap. But secondly, I think you'll learn so much by just asking the community, what does the space mean to you? And I have two really good examples of that. I talked to one individual who'd received pretty much every service we'd offered, anywhere from STI testing to HIV testing to eventual linkage to care, as that person was eventually seroconverted, and everything in between, including housing and mental health. And I was like, what does Project Silk mean to you? And he was like, I don't know, I just feel like it's a space for people to dance. You know, and so, you know, almost said with derision, which was really interesting. He liked it, he used it to dance, but he thought that's all we were, even though he'd been through all of those other services, which is really interesting. And then I talked to another individual who's also, we've had some people who've used the space every day for the 3 years that we've been open. We opened in 2013. And one of the people that I've talked to said, you know, I asked him, what did it mean to you, and why do you come back? And he said, Basically, it's just the best gay experience of my life. And that really touched me. That really moved me. I don't even know what that means, but I thought about when's the first time I went to, a gay space, and what was that like for me? And, I think those things can be really awkward. They can be really uncomfortable. If they're in bars, you feel like you need to get drunk. You don't know anybody. How do you talk to people? There are these kind of contrived structures, and what we try to do is create an organic structure that people can use on their own to develop community. And for him to say that and have one of the first gay spaces he entered be the best gay experience of his life is something that we never anticipated when we developed this particular project, but I think is also really meaningful and moving. Oh, and I wanted to say that in conversations with Ife, she's also talked about how maybe as an unintended effect, Crush has wound up being a safe space for people to come to, and wanted to give her the opportunity to talk more about that.
Yeah, I mean, one of the things that was really amazing for us to watch as we implemented the study and started seeing the project from the beginning with the trickle of people that started coming through the door in 2014 when we this huge, at the beginning of 2015 was that the project itself started to realize that the clinic had become a place of safety for young gay men of color, that they would come not just to come and get sexual health services routinely, but they would come to actually hang out. We created a huge waiting room with a huge television in it, and a place where they could plug in their phones and get snacks and things like that. And it showed us that, again, there was this need to create safe spaces, as Mackey addressed, that address the social spheres of this group of men who needed and still need places where they can come and feel like they can engage with their community, engage not just with providers and be connected to something larger than the implementation.
You're breaking up just a little bit, Ife. If you can talk into the mic.
Is that better? Yes, no?
Now it's a little bit of yes.
Yes, no? Okay. We're on the next slide, moving into policy. Or, Mackey, are we on? Next slide.
Next slide.
Turn it back over to Mackey. Yeah.
Okay, Matt?
Oh, I'm here. I'm sorry, I was on mute. I wanted to talk about some quick policy implications, and I think that we've seen as grants have come through that, can you hear me?
Yes.
Okay, great.
Is this the correct slide?
Not quite. Seen as grants as our grants are coming through the pipeline from NIH, from HRSA, from CDC, from SAMHSA, they are tending to have more and more requirements as far as community-based participation, and we think that's going to continue because of outcomes like our programs that have been shown nationally and internationally. But we also want to make sure that agencies expect pushback, and Ife kind of alluded to this earlier, that there is resistance to CBPR from multiple sources, anywhere from fellow staff to people you share buildings with, to your administration, to funders, to agencies that you collaborate with. And we wanted to let everybody know that we were available to kind of help them talk through strategies to deal with that pushback. Whether that's arranging meetings and using these CBPR approaches or CBP approaches to deal with that pushback around sort of collecting folks' ideas and working together towards solutions. So we've had some good examples of that, and we'd be happy to share with folks privately after the call. So I think we wanted to also just wrap up and say, you know, there are some mottos and some things to remember here. The CBPP approach that I've used is ask, listen, act, and then ask again. In other words, I've known a lot of people who ask but don't listen, or who ask and listen but never act. And those approaches are never going to generate community investment in the project and the work that you're doing, or community trust, that you're really looking out for the solutions the community has responded to in your discussion. You do ask, listen, act, and then you ask again, is this working? You can really generate programs that are salient to the communities that you serve. Similarly, plan, do, study, act has long been a tenet of community-based participatory research. And ultimately, all I think we're suggesting is flexibility to the needs of the communities that you serve within the constraints of your program. And that you keep your sense of humor. So takeaways. You know, communities, funders, practitioners often want different things and different outcomes. And taking these complexibilities and tensions into account is really paramount in planning programming. And CBPR can help you do that. CBP can help you do that. And the real advantage is that it can help sort of translate the needs of funders to communities, but more importantly, I think, communities to funders. So that instead of shoehorning your community-generated ideas into an existing grant structure, you can get some structures that are out there that really do meet those holistic needs. Well, cheers. And we feel like in a dynamic and flexible process, this can help optimize programming so that everybody gets what they want, including you. And I'm going to turn it over to you. Some acknowledgments.
Awesome. Thank you so much, Ife and Matt. We really appreciate this robust and rich conversation. We are rounding out to the end of the hour and 15 minutes, but we did want to take a few minutes to do some quick Q&As. We're going to take about 2 to 3, and then we are collecting your questions to send to Mac and to Ife following the webinar. The first one, some folks had some really good feedback around, but those of you dissecting that phrase, that hard-to-reach phrase, and it really sounds like what you're rounding out to saying is that Black MSM patient communities are not at all hard to reach. It's really that we are having challenges as sort of public health entities who are tasked with doing work to engage them. We are having a hard time learning how to reach. And so from both of you, we would just love to get some quick sound bites from your mouth to public health authorities' ears. What are some guiding principles that help us as public health officials learn how to better reach these communities?
That's actually really great feedback, and I'm really glad somebody brought that up. Mackey and I spoke about that at length in terms of this framing around about young gay men of color and specifically Black gay men as being hard to reach. And as I think both of us as being public health practitioners absolutely understand that is the terminology that we're using to describe this population as being hard to reach. And rather than thinking about it from the perspective of we or us, and those of us that don't know how to reach, don't know where to engage communities, it's a question of we're not asking the right and appropriate questions, and we're not being thoughtful about, well, is it really that they're hard to reach, or is it that we're framing them as being hard to reach because the communities may or may not want us to be reaching out to them. I mean, we have to be sort of conscious and aware of, again, where and when I enter. And there is, as we know, it's a lot of the work that's being done in organizations such as Black Lives Matter is this idea that communities are empowered and need to be empowered to work amongst themselves first before they develop mechanisms for trusting others to come in. And I really believe strongly that we should debunk this sort of theory that Black gay men are hard to reach per se. I don't know if Mackey has anything to add to that. Yeah,
you know, I absolutely agree, you know, with what Ife said. I think there's also a component of there's this framing right now that I don't like, and it's not something that I feel like NASTAT's contributing to. In fact, I think that this is a really nice rejoinder to that framework. But that framework that gay black men are, you know, nothing but inspectors of infection, I don't think that framework does anybody any good. I think it's not holistic. I think it treats gay black men as potential disease carriers of a virus and doesn't see them as anything beyond that. And so if I were a gay black man and I saw a research project that was trying to reach me about HIV-related stuff, I would probably run away because, you know, I don't like that framing. I don't think it's helpful. I don't think it would describe me as a person if you know, if I was in that target population. So I think that's a little bit of a part of it. I think there's this kind of sense of being over-researched and exploited in that research. I think there's been a lot of helicopter research, and that's like sort of researchers coming in and doing research in communities and then not doing programmatic work to solve these, you know, these issues, the public health issues that the research shows. So we've known about disproportionate HIV rates in gay black male communities for how many years now, and how many programs have been developed that have been sustained? How much have we really built the public health infrastructure to counter, you know, these issues? We haven't. You know, we've done research, but we've flown right back out again. And I think also, who does that research, you know, and what we really need to be concentrating on is building capacity and building infrastructure so that the research can be done by communities for communities instead of folks kind of flying in, doing the research and running away and leaving and saying, oh, look at how horrible that community is doing, because that's just not helpful.
Exactly. Several more questions. I'm just going to give you one more, and then we'll respond to folks via email. A participant wants to know from both of you, for your Youth Advisory Board and your Community Advisory Board, does the program support any mentorship opportunities? There is, I believe, an age limit that you both mentioned for the program, so if someone ages out, there's an opportunity to train someone to become a CAB member and contribute.
That's a really great question, and the answer to that is yes. Our Community Advisory Board is rooted in that concept of mentorship and co-learning, and I'll give a couple of really concrete examples. One, we have sent a number of our Community Advisory Board members to conferences that are relevant to the work of CRUSH and relevant to their own learning. We just sent a member to the YGBLI conference down in Baton Rouge a few weeks ago. We have sent one of our Community Advisory Board members to DC to go speak on a panel alongside Dr. Robert Grant, the protocol chair for IPREX. We've also mentored our CAB to be our, as I mentioned earlier, our media representatives. So, for example, one of our CAB members in particular has done 2 NPR interviews through youth radio that are posted online that can be accessed, and he's been the person that we actually call him our media guru. He actually is the person that goes out and talks for us on behalf of the media. He's been interviewed in the French paper Le Monde, which, as you may or may not know, France just recently passed their own national protocols around implementing PrEP, and when they came to visit the United States to learn about different PrEP programs and to learn specifically about how we were doing things at CRUSH, when the actual paper articles came out in France, it was Mackey who was on the front page cover of the Monde. And so we definitely promote and expect our advisory board members to step up to the plate, and we spend a lot of time mentoring them on how to develop presentations, how to do public speaking, those kinds of things.
That's awesome. Mac, anything to add to that? Thank you for those really rich examples of community engagement in action.
Yeah, the only thing that I would add for us is we really tried to establish a pipeline from community advisory board engagement to peer staffing, and we really hope that our, our stars at the community advisory board level will sort of get that leadership experience there and through some of the opportunities they have through that board interfacing with other agencies to really step in and become peer mentors and peer workers and peer staff folks. And then that's creating new opportunities for new youth advisory board members to step in, fill their plates, and then also achieve.
Awesome. Well, I feel like I juiced you all for a lot, and I'm so thankful for you all sharing your rich experience. Mac and Ife will be joining us further down the line for His Health webinar series, which will go through to July 2016. We have their contact information as well. Please feel free to email His Health at any time, and we look forward to seeing you again to continue this discussion on lifting the standard of care for Black gay men. Ife and Mac, thank you so much. Everyone have a great weekend.